Good afternoon. Our topic is about the posterior compartment of the thigh and the hip joint. For the cutaneous innervation on the back of the thigh, we have the posterior cutaneous nerve of the thigh, which is a branch of the sacral plexus. So this is the posterior cutaneous nerve of the thigh. It leaves the gluteal region by emerging from beneath the lower border of the gluteus maximus muscle. It descends on the back of the thigh, and in the popliteal fossa, it pierces the deep fascia and supplies the skin. So it gives off numerous branches to the skin on the back of the thigh and the upper part of the leg. So it innervates the back of the thigh as well as the upper part of the leg. For the superficial veins, many small veins curve around the medial and lateral aspects of the thigh and ultimately drain into the greater saphenous vein. So these are the veins found in the thigh, and it drains into the greater saphenous vein. The greater saphenous vein drains into the femoral vein. The superficial veins from the lower part of the back of the thigh joins the small saphenous vein in the popliteal fossa. So this is the small saphenous vein. So from the lower part of the thigh, it drains into the small saphenous vein. The small saphenous vein drains into the popliteal vein. For the lymph from the skin and superficial fascia on the back of the thigh, it drains upward and forward into the vertical group of superficial inguinal nodes. So this is the superficial inguinal nodes. It receives lymph vessels from the thigh as well as from the lower part of the extremity. So what are the contents of the posterior fascial compartment of the thigh? So we have the group of muscles, the biceps femoris, the semitendinosus, the semimembranosus, and a small part of the adductor magnus, which is the hamstring muscle. So these are the muscles found on the posterior part of the thigh. So this is from the back of the thigh. So this is the biceps femoris, the semitendinosus. It has a long tendon, that's why it's called semitendinosus, and the semimembranosus. So it originates from the ischial tuberosity. So this is the adductor magnus, and this is the hamstring part of the adductor magnus. It also originates from the ischial tuberosity. So the blood supply comes from the branches of the profunda femoris artery. The profunda femoris artery is a branch of the femoral artery. So the nerve supply is from the sciatic nerve. So these are the muscles of the posterior fascial compartment of the thigh. The biceps femoris, the long head, originates from the ischial tuberosity, while the short head originates from the linea aspera on the lateral supracondylar ridge of the shaft of the femur, and it is inserted into the head of the fibula. So the long head is innervated by the tibial portion of the sciatic nerve, while the short head is innervated by the common peroneal nerve, which is also a branch of the sciatic nerve. So the action of this muscle, it flexes and laterally rotates the leg at the knee joint, while the long head extends the thigh at the hip joint. The semitendinosus originates from the ischial tuberosity, and it is inserted into the upper part of the medial surface of the shaft of the tibia. The nerve supply is from the tibial portion of the sciatic nerve, and its action is flexes and medially rotates the leg at the knee joint, and it extends the thigh at the hip joint. While the semimembranosus originates from the ischial tuberosity, inserted into the medial condyle of the tibia, nerve supplies from the tibial nerve. The same action flexes and medially rotates the leg at the knee joint, and it extends the thigh at the hip joint. While the adductor magnus, the hamstring portion, also originates from the ischial tuberosity and is inserted into the adductor tubercle of the femur. The nerve supplies from the tibial nerve. The action, it extends the thigh at the hip joint. Note of the following. So the adductor magnus, the hamstring part, is innervated by the tibial portion of the sciatic nerve, while the adductor part is innervated by the obturator nerve. The semimembranosus insertion sends a fibrous expansion upward and laterally, which reinforces the capsule on the back of the knee joint. So this structure is referred to as the oblique popliteal ligament. So this is the insertion of the semimembranosus, and it sends an expansion upward and laterally, and this structure is referred to as the oblique popliteal ligament. The nerve supply of the posterior compartment of the thigh comes from the sciatic nerve. So the sciatic nerve is a branch of the sacral plexus. L4 and L5, S1, S2, and S3. So it leaves the gluteal region as it descends in the midline of the thigh. It is overlapped posteriorly by the adjacent margins of the biceps femoris and the semimembranosus muscle. It lies on the posterior aspect of the adductor magnus muscle. This is the sciatic nerve. So it's covered by the biceps femoris and the semimembranosus muscles. So it terminates into two branches, the tibial nerve and the common peroneal nerve. In the lower third of the thigh, it ends by dividing into the tibial and the common peroneal nerves. So the branches of the sciatic nerve, the tibial nerve, the common peroneal nerve, and the muscular branches. The tibial nerve is a terminal branch of the sciatic nerve, and it enters the popliteal fossa. While the common peroneal nerve is also a terminal branch of the sciatic nerve, and it enters the popliteal fossa on the lateral side of the tibial nerve. So this is the tibial nerve. Again, on the lateral side, the common peroneal nerve. These are the branches of the tibial nerve. The muscular branches, it has muscular branches to the long head of the biceps femoris, the semitendinosus, the semimembranosus, and the hamstring part of the adductor magnus. So these branches arise from the tibial component of the sciatic nerve and runs medially to supply the muscles. Another topic is the hip joint. So the hip joint is the articulation between the hemispherical head of the femur and the cup-shaped acetabulum of the hip bone. This articulation between this is the head of the femur and the acetabulum of the hip bone. So this is the acetabulum, the head of the femur. The articular surface of the acetabulum is horseshoe-shaped and is deficient inferiorly at the acetabular notch. This is the acetabular notch. The cavity of the acetabulum is deepened by the presence of the fibrocartilaginous rim called the acetabular labrum. This is the acetabular labrum. So it deepens the acetabulum. This is acetabular labrum. This one. The labrum bridges across the acetabular nuts, and this is called the transverse acetabular ligament. This is the transverse acetabular ligament. The articular surfaces are covered with hyaline cartilage. And this is the hyaline cartilage covering the articular surfaces. Depth joint is a synovial ball and socket joint. The capsule encloses the joint and is attached to the acetabular labrum medially. So laterally, the capsule is attached to the intertrochanteric line of the femur in front and halfway along the posterior aspect of the neck of the femur behind. This is the capsule attached to the labrum and to the trochanter of the femur and the neck of the femur. So this is the capsule. At its attachment to the intertrochanteric line in front, some of its fibers accompanied by blood vessels are reflected upward along the neck as bands called the retinacula. So these blood vessels supply the head and neck of the femur. So it's the blood supply of the head and neck of the femur. So the ligaments of the hip joint, number one is the iliofemoral ligament. So this is the iliofemoral ligament. It's an inverted Y-shaped ligament from the anterior inferior iliac spine to the upper and lower part of the intertrochanteric line. So the iliofemoral ligament is a strong inverted Y-shaped ligament. So its base is attached to the anterior inferior iliac spine above. Below, the two limbs of the Y are attached to the upper and the lower parts of the intertrochanteric line of the femur. This strong ligament prevents overextension during standing. Another ligament is the pubofemoral ligament. So this is the pubofemoral ligament from the superior ramus of the pubis to the lower part of the intertrochanteric line. The pubofemoral ligament is triangular, so the base of the ligament is attached to the superior ramus of the pubis, and the apex is attached to below to the lower part of the intertrochanteric line. So this ligament limits extension and abduction. The third ligament is the ischiofemoral ligament. So this is the ischiofemoral ligament, a spiral-shaped ligament from the body of the ischium to the greater trochanter. So it is spiral-shaped and is attached to the body of the ischium near the acetabular margin. So the fibers are attached to the greater trochanter. So this ligament limits extension. Fourth ligament is the transverse acetabular ligament. So it is formed by the acetabular labrum as it bridges the acetabular notch. This is the transverse acetabular ligament. The ligament converts the nuts into a tunnel through which the blood vessels and nerves enters the joint. So posterior to the ligament, the nerves and the blood vessels enters the joint. Another ligament is the ligament of the head of the femur. Yes, the ligament of the head of the femur. So this ligament is flat and triangular. It is attached by its apex to the pit on the head of the femur, the fovea capitis, and by its base to the transverse ligament and the margins of the acetabular notch. It lies within the joint and is encircled by synovial membrane. So the synovial membrane lines the capsule and is attached to the margins of the articular surfaces. It covers the portion of the neck of the femur and lies within the joint capsule. It encircles the ligament of the head of the femur and covers the pad of fat contained in the acetabular fossa. A pouch of synovial membrane frequently protrudes through a gap in the anterior wall of the capsule between the pubofemoral and the iliofemoral ligament. There is the pouch of synovial membrane protruding between the pubofemoral ligament and the iliofemoral ligament and forms the psoas bursa. So that's the psoas bursa beneath the psoas tendon. The nerve supply to the hip joint is from the femoral, the obturator, the sciatic nerve, and the nerve to the quadratus femoris. For the movements, the hip joint has a wide range of movements. So the strength of the joint depends largely on the shape of the bones taking part in the articulation and the strong ligaments. So this is the wide range of movement of the knee joint, of the hip joint. When the knee is flexed, flexion is limited by the anterior surface of the thigh coming in contact with the anterior abdominal wall. And when the knee is extended, flexion is limited by the tension of the hamstring group of muscles. So when the hip knee is flexed, so flexion is limited by the anterior abdominal wall. But when the knee is extended, flexion is limited by the tension of the hamstring group of muscles. So these are the movements of the hip joint. Extension. Extension is the movement of the flexed thigh backward to the anatomic position, which is limited by the tension of the iliofemoral, the pubofemoral, and the ischiofemoral ligaments. So this is extension. Abduction is limited by the tension of the pubofemoral ligaments. Adduction is the movement away from the body or away from the midline. While adduction is limited by contact with the opposite limb and by the tension of the ligament of the head of the femur. And this is adduction. So it is a movement towards the midline or towards the body. While lateral rotation is limited by the tension of the iliofemoral and the pubofemoral ligaments. This is lateral rotation. So it's the movement of the hip joint to the outside. While medial rotation is limited by the ischiofemoral ligament. This is the medial rotation to the inside. So these are the muscles responsible for the movement. So the flexion is performed by the iliopsoas, the rectus femoris, and sartorius, and also by the adductor muscles, while extension is performed by the gluteus maximus and the hamstring muscles. Adduction is performed by the gluteus medius and minimus, assisted by the sartorius, the tensor fasciae lata, and the piriformis. Adduction is performed by the adductor longus and brevis and the adductor fibers of the adductor magnus. So these muscles are assisted by the pectineus and the gracilis. While lateral rotation are performed by the piriformis, obturator internus and externus superior and inferior gemini, quadratus femoris assisted by the gluteus maximus. Medial rotation are performed by the anterior fibers of the gluteus medius and minimus and the tensor fasciae lata. While circumduction is the combination of all the previous movements. So the extensor group of muscles are more powerful than the flexor group, while the lateral rotators are more powerful than the medial rotators. So important relations anteriorly. So anterior to the joint, the iliopsoas, pectineus, the rectus femoris muscles. The iliopsoas and pectineus separates the femoral vessels and nerve from the joint. So posteriorly, so these are the structures posterior to the hip joint. Obturator internus, the gemini, quadratus femoris. So the muscles separate the joint from the sciatic nerve. Superiorly, the piriformis and the gluteus minimus, and inferiorly, the obturator externus tendon. For the clinical notes, referred pain from the hip joint. The femoral nerve supplies the hip joint. So the femoral nerve also has branches, the intermediate and the medial cutaneous nerve of the thigh, so that pain or inflammation of the hip joint so may be referred to the front and medial side of the thigh because of this innervation, then because of the intermediate and the medial cutaneous nerves of the thigh. So the posterior division of the obturator nerve supplies both the hip and the knee joint. So this is why I explained the hip joint. Hip joint diseases sometimes gives rise to pain in the knee joint. Conditions of the hip joint. Number one is the congenital dislocation of the hip. So the stability of the hip joint depends on the ball and socket arrangement of the articular surfaces and the strong ligaments. So in congenital dislocation of the hip, the upper lip of the stabilium fails to develop adequately. So the head of the femur having no stable platform under which it can lodge, rides up out of the stabilium onto the gluteal surface of the ilium. So this is the defect in congenital dislocation of the hip joint. So normally, ito siya complete yung stabilium. So in congenital dislocation, so it is deficient superiorly, posteriorly, so that the femur is displaced backward and upward. Another condition is traumatic dislocation of the hip. So traumatic dislocation of the hip is rare because of its strength. So it is usually caused by motor vehicle accidents. This usually occur when the joint is flexed and adducted. So the head of the femur is displaced posteriorly out of the stabilium and it comes to rest on the gluteal surface of the ilium. So this is referred to as posterior dislocation. This is traumatic dislocation of the hip. So the head is displaced posteriorly out of the acetabulum. This is the normal anatomy. The close relation of the sciatic nerve to the posterior surface of the joint makes it prone to injury in posterior dislocation, so that the sciatic nerve may be injured in posterior dislocation of the joint. Hip joint stability and Trendelenburg sign. So the stability of the hip joint, when a person stands on one leg with the foot on the opposite side raised above the ground, depends on three factors. So the gluteus medius and minimus must be functioning normally. The head of the femur must be located normally within the stabulum, and the neck of the femur must be intact and must have a normal angle with the shaft of the femur. If any one of these factors is defective, then the pelvis will sink downward on the opposite unsupported side, so the patient is said to exhibit a passive Trendelenburg sign. So this is yun, is positive Trendelenburg sign. So there's drop of the pelvis when lifting the leg opposite to the weak gluteus medius minimus, gluteus medius muscle. So the opposite side will sink when the patient stands on one leg. So supposedly ito yung normal. So in positive Trendelenburg sign, there is sinking of the opposite side of the pelvis. Pag tumayo siya with one leg only. A patient with a right-sided congenital dislocation of the hip, when asked to stand on the right leg and raise the opposite leg clear of the ground, will exhibit a positive Trendelenburg sign. And the unsupported side of the pelvis will sink below the horizontal. So if the patient is asked to walk, the patient will show the characteristic dipping gait na inka. So if the patient with bilateral congenital dislocation of the hip, so the gait is waddling in nature. Nagsway-sway. Another condition of the hip joint is arthritis. So patient with an inflamed hip joint will place the femur in the position that gives minimum discomfort. So that is the position in which the joint cavity has the greatest capacity to contain the increased amount of synovial fluid secreted. So this is the position with minimum discomfort. The hip joint is partially flexed, abducted, and externally rotated. Osteoarthritis is the most common disease of the hip joint in the adult. It causes pain, stiffness, and deformity. The pain may be in the hip joint itself or referred to the knee. So this is via the obturator nerve, which also supplies the knee joint. The stiffness is caused by pain and reflex spasm of the surrounding muscles. So the deformity in osteoarthritis is flexion, adduction, and external rotation, and is produced initially by spasm of the muscles and later by contracture. I think that's the end of the slide. Okay. Do you have questions? Kailan ang ano nyo? Report by monthly. Do you have the schedule? May schedule na tayo ng report by monthly.
Meron na po, Doc. Pero hindi pa nakalagay yung subjects.
Okay. May mga topic pa ako, ano?
Meron pa po, Dok.
Okay. Wala kayong question? Sige, ano ko na lang, email ko na lang yung PowerPoint.
Sige po, Dok. Thank you po.
Thank you. Okay.
Thank you, Doc.
Thank you.
Thank you, Dok.
Thank you, Doc.
Thank you,
Doc.
Doc.
Thank you.
Thank you po, Doc.
Thank you, Doc.
Thank you, Doc.
Okay. Thank you.
Thank you, Doc.
Thank you, Dok.
Thank you, Doc. Doc.
Thank you, Doc.
Doc, quick question na.
Yes, yes.
Regarding mga bursitis, ano approach ito, Doc?
Bursitis.
Like subtrochanteric bursitis. Ano kwento nga approach, Doc? Either ipa-rest laan niya or continue with current na exercises na may daniya.
And kwan manggo dito, what is advice is to rest and anti-inflammatory. Intertrochanteric.
Subtrochanteric la, Doc.
Anteric. Hinon may hinon may bursitis.
May ako kasi kilala nga ginahandle ko yan. So aniyala chief complaint is just pain during prolonged sitting.
Hinon may PT ayo dida. Hinon may PT.
Ako, Doc, PT ako, Doc.
PT ka. Oh.
So
mga inflammation nga niya joints and kung ito impaparest anay. Ano ba pwede kung inflamed diha pwede kuan cold compress then later warm so gaditon. Pero ang kuan dida anti-inflammatory medications. And bursitis di ba bursitis parang caution kasi tiya di ba? Oh, caution itiya between two structures. Nagkakadaya ito common kun kuan bagay infraction na prevent yan friction between two structures. So kung nagkaka-bursitis ka karag sigmon kuan gyud pa no PT.
yes, Doc.
Yes, Dok.
Ano ni mo opinionan, di ba? Hindi discuss ito niyo. Kasi may specialties actually kuan general surgery. So mga bursitis it's an orthopedic. Pero ang kuan man ito pag inflamed, i-rest mo, take anti-inflammatories, katapos to decrease the inflammation, pwede ka maghatag in kuan, cold compress, pag minimize ang pain, warm. So gaditon. Okay. Amon malati ang principles.
Joint protection na talaga, Doc.
Kay bursitis, amo matyan ang function ng mga bursa para tiya kasi in kuan caution in between two structures sa tiya nga structure. Amo nakapagkakuan. Actually, I'm not a kuan, I'm not an orthopedic. I'm a general surgeon.
And kuan na kasi namon, Doc, yan, namon concern is hindi pwede maoperahan anay kay tungod it iya work.
Kay ano gin-advise sa iya? Usually yan mga kuan ito gintatagan ito ran mga anti-inflammatory. So ang management initially is bagahin kuan minimal invasive. Minimal invasive pwede mga steroids basta mga anti-inflammatory. Either mga intra-articular ang gini-inject or pwede gin-take.
Pero di naman tumawarrant tayo ng surgery
Anak surgery.
Di naman if possible.
Depende kasi tayo maging kakadto. Kung Rio makamakadto, ibang specialty, treat kanira, kuan, amo na ito, mga intra-articular injections. Pero I don't know kung pumadto ka surgeon. Pero before kay OR, ginpay maraiya. Anong defect? Bangin may da concomitant injury, dirilan kuan bursitis. May ligament tear, may da kunani joint o DD, bangin may da nga problem. So, before ka magpa-opera, i-investigate ito. MRI. You can ask me questions. Kung mas maupay ko na niyo papakyan about mga general surgery questions. Pero okay, gihapon.
Thank you, Doc.
Magkikirita kita next year. I am in charge of the surgery 1. You can ask me questions also.
Okay, Doc. Thank you po.
Okay, sige. Alright na, ma-out na ko.